So we are live.
Mayank, can we go live now?
Yes, we are live.
Good evening, everyone. Today we are here again with another webinar of ACP India case files. And today we are having very good case lined up, which is going to be taken by Dr. Jalis Fatima, and a very good discussion on mentorship, for which we have Dr. Bansi Sabu with us. But before that, I would like to invite or introduce our governor, Dr. Anush Maheshwari, who is the governor of ACP India Chapter. And this is his initiative, which is now being globally renowned, and now many people look forward for this ACP India Chapter webinar series. So welcome, Dr. Anuj sir, and I will request you to please proceed with the program.
Thank you, Amit, and welcome all the members of the ACP India chapter, as well as members those who are joining from other chapters of the ACP. So greetings from India to all of you, and I believe that you must be enjoying this series of the ECP case file, which is specially designed for the early career physician. In the same series, this month we are coming up with a very innovative case file, which will be presented by Professor Jalis Fatima. She is not only professor in Iraz Lucknow Medical College, but also she is treasurer of India chapter of American College of Physicians. She will be presenting a very innovative and uncommon presentation of hyperthyroidism with pulmonary hypertension. As this particular case is involving two specialties together. One is the respiratory medicine and another is the endocrinology. So we are really looking forward to a pulmonologist who is heading the unit of this pulmonary hypertension or pulmonary hypertension clinic is running in KGMC, Dr. Jyoti Bajpayee. Dr. Jyoti Bajpayee is assistant professor in King George Medical University, where she runs the clinic of pulmonary hypertension. And she will be giving her expertise on the case. At the same time, she will be moderating the session. And I welcome Dr. Jyoti Bajpayee and will request Dr. Jyoti Bajpayee to introduce the speaker and start the program from the first part, in which this ECP case file will be presented by Dr. Jalis Fatima. Over to Dr. Jyoti Bajpayee.
So very good evening to all of you. So I feel very honored and privileged to work as a moderator on American College of Physicians India Chapter Case Files platform. And at the outset, I would like to thank Dr. Anuj Maheshwari for giving this opportunity to me. So I am very grateful, sir. And it is a matter of great prestige that India Chapter of American College of Physicians has received the 2022 John Tukin Evergreen Award for this program. I just got this information, so I would like to share it. So case files for early career physicians. So it is a very good platform for early career physicians. This program is dedicated to early career physicians and support or guide them how to handle challenging cases and clinical scenario. In the continuation of this, for today's challenging case, I would like to invite Dr. Jalis Fatima ma'am. She is a professor and head Iraz Medical College, Lucknow, Department of Medicine. As Sir already told about today's case discussion topic is based on pulmonary hypertension and hyperthyroidism. So as we know that pulmonary hypertension is an ever-changing field where clinicians face a myriad of diagnostic and therapeutic challenges, because the clinical symptoms and signs of pulmonary hypertension are very similar to other cardiac and respiratory diseases. So it is a chronic progressive disease it was it was firstly described by the in First World Symposium in 1973. So since then, this pulmonary hypertension is evolving. Its definition is changing. There are a lot of changes has been occurred in last 60, 70 years. So 50 years. So I would like without any delay, I would like to invite Dr. Jalise Fatima ma'am for the wonderful discussion on the topic pulmonary hypertension and hyperthyroidism.
Thank you very much, Dr. Jyoti Vajpayee. I'm really honored and uh, I thank a lot to our Governor ACP for inviting me for this important discussion, which is a prestigious in the way it is a prestigious program that it involves the early career physician. So can you see my screen?
Yes, ma'am.
Yes, we can see your screen.
Okay. So without delay, I will start this presentation, and this is
Make it full
just a
screen.
minute. Just a minute. Yes. Is it okay now?
Yes.
So, the topic is hyperthyroidism and pulmonary hypertension, an uncommon presentation. It is an uncommon presentation, but not an uncommon association. That's what I want to emphasize in this presentation, in this case report, which I'll be just presenting in front of you. That hyperthyroidism has its cardiovascular complications, that is very well known, and pulmonary hypertension is one of those. In many cases of pulmonary hypertension, where we do not have a common cause like a left heart failure or a pulmonary disease, and we exclude all other causes, we say that the pulmonary hypertension is a primary pulmonary hypertension. But there can be some other causes. The WHO has made the classification of pulmonary hypertension in the 5 classes, and hyperthyroidism as a cause of pulmonary hypertension falls in the 5th class of the causes of pulmonary hypertension. So let us look into this interesting case. There was a 40 or 45 years old female who presented as an inpatient in the Era Medical College. She was married, housemaker, and presented with a breathlessness of exertion and cough with expectoration, which was present there for last 3 months. This breathlessness on exertion was insidious in onset to present with, and it was first noticed while she was doing her household work and got relieved after taking some rest for around 10 to 15 minutes. It gradually progressed for over the last 3 months from MMRC grade 1 to grade 4, and then she had this worsening more severe, and over the last 4 to 5 days before presentation she was bedridden, and she presented to us in a condition when she was having orthopnea and palpitations also added upon as a symptom. There was no history of any diurnal or postural variation, and no history of paroxysmal nocturnal dyspnea, chest pain, or any wheezing. The cough and expectoration was present for 3 months, but for 3 weeks it was more severe, and this was insidious in onset and gradually worsened, and it was associated with a sputum production of 5 to 6 teaspoons per day, and at times it used to be more. It was whitish yellow in color, thick in consistency, mucopurulent, non-foul smelling. There was a history of 3 episodes of blood streaking of the sputum in the last 3 months. It was bright red in color and occurs in the forms of streaks over the lump of the sputum. There was no postural or diurnal variation of the sputum, and the patient complained about significant weight loss over this 3 weeks and especially the 3 months period. There was this important past history that the patient had pulmonary tuberculosis 3 years back and taken treatment for about 3 months and discontinued on her own. So it was a case of an inadequately treated and a drug default. Later on, the patient just left to the follow-up of the physician or the pulmonologist who were treating that patient. There's no history of diabetes, hypertension, or any known hypo or hyperthyroidism in that patient. She was taking a mixed diet. The appetite was markedly reduced and the sleep was also reduced with the increased latency of sleep onset. And the sleep duration was also reduced. Bowel and bladder habits were normal. There is a history of tobacco chewing. Her obstetric and menstrual history was she was a P6, L6, and the last childbirth was 6 years old with a normal delivery at home. There was nothing very significant except that there was a reduced flow lasting for about 1 to 2 days over last 3 months. The cycles became irregular. There was nothing significant in the family history. She belonged to a lower middle class according to the modified Kupuswamy scale. When I examined that patient, the pulse rate was 150 beats per minute, regular, hypervolumic. There was no special character and no radioradial or radiofemoral delay. It was synchronous. Condition of the arterial wall was normal and all the peripheral pulses were felt normally. As the patient presented with a slight fall in the SpO2, she presented with a 90%. She was put on nasal oxygen. She was given oxygen by nasal prongs for 1 to 2 liters intermittently, and then she used to maintain it in between. Blood pressure was 110 by 70 millimeter mercury in the right arm. Respiratory rate was 24 breaths per minute, and she was having a 99.7 degree Fahrenheit temperature. That means around 100 fever, 100.7 in. Yes. So on examination, the patient was severely malnourished. The BMI was 11.6 kg per meter square. There was no pallor icterus, no clubbing cyanosis, and no pedal edema. There was bilateral multiple cervical lymph nodes palpable, 6 to 8 in number on either side, discrete, mobile, soft in consistency. Maximum was 1 centimeter in size and not attached to the underlying structure. No overlying skin changes were there. The JVP was normal. On examination of the neck, the thyroid was symmetrically enlarged, soft in consistency and moving with deglutition. There was no bruit over the thyroid. This is the picture of the neck where you can see the goiter, which is quite evident in this picture. On systemic examination, the chest was symmetrical. There was an important finding that the apical impulse was visualized in the fifth intercostal space lateral to the midclavicular line, and the movements were bilaterally equal. Rest of the things were normal except that there was a use of accessory muscles of respiration which was visible. The trachea was slightly shifted to the right and that was taken as normal. Apex beat palpable at fifth intercostal space 2 centimeters lateral to the midclavicular line. The character of the apex was normal. The chest movements are bilaterally symmetrical, but the chest expansion is 2 centimeters, that is significantly reduced. AP diameter 16 centimeters, transverse 23, AP to transverse ratio 0.7, and there were resonant note is heard bilaterally over all areas of percussion. On auscultation, bilateral coarse leathery creps heard over both the lung fields over all the areas of examination. However, this coarse leathery crepitations were more on the left side as compared to the right side. On cardiovascular examination, the apex apical impulse was visualized in the fifth intercostal space lateral to the midclavicular line. The apex beat was palpable at the fifth intercostal space 2 centimeters lateral to the midclavicular line. Parasternal heave of grade 3 was present, and there was a palpable P2 in the pulmonary area. On auscultation in the mitral area, S1 and S2 were heard with no added sounds, they were normal, and in the tricuspid area there was a high-pitched rumbling pansystolic murmur of grade 3, which was non-radiating, heard best with the diaphragm of the stethoscope, with the patient in supine position and breath held in deep inspiration. P2 was loud with a narrow split. In the aortic area, S1 and S2 were heard and no added sounds were there. So in the initial workup, considering the tachycardia and the goiter which was present in the patient, we have had done a thyroid profile which showed that the thyroxine was very high, a T4 was more than 320 and the T3 was also much above the normal, and the TSH was less than 0.01 milli-IU per liter. So it was a case of hyperthyroidism. And among the other CBC, we can see that there is no significant finding, important finding, and it is normal, fairly normal. On ECG, there was sinus tachycardia. As we have received the patient at the time of admission, the patient's pulse rate was 150 beats per minute. Here also we can see that the rate is 141. Sinus tachycardia is there, the rhythm is regular, and we can see that the P wave is prominent with a peaking of the P wave, that is P pulmonale is present. And here in the V1 we can see that the R wave is prominent, which is showing the right ventricular hypertrophy. This is a chest x-ray of the patient, which is showing the few patchy areas of ground glass opacities in the left, middle and lower zones, and cystic bronchiectatic changes are noted in the left upper and middle zone, predominantly in the perihilar regions. Findings concern infective etiology. We had done further workup on this patient. As the patient had a history of pulmonary tuberculosis and there was a she left the treatment after 3 months of the taking the ATT, then sputum, we have examined the sputum, which came out to be negative for acid-fast bacilli. Free T4 was done, which was also elevated, and anti-TPO antibodies were high. The ultrasound of the thyroid revealed heterogeneous echo texture of both the lobes. Here we can see the image. The 2D echocardiography showed a mildly dilated right atrium and right ventricle and the moderate tricuspid regurgitation with a jet velocity of 3.8 meters per second. Suggestive, and the RVSP was approximately 60 millimeter of mercury, suggestive of severe pulmonary arterial hypertension. This is the Hrct thorax images of the patients where we can see that these are the multiple cystic and varicoid bronchiectatic changes with the cavities in the left lung field with multiple discrete confluent nodules with tree in bud appearance in the left lower lobe with a few fibrotic patches noted in bilateral upper lobes, findings which suggest an acute and chronic infective etiology. So we thought of a reactivation of tuberculosis in this patient. So what was the course during hospital stay? When I saw this patient first in my ward HDU, I saw that the patient was on minimum oxygen 1 to 2 liters and she was having tachycardia. So her liver was slightly, there was just palpable liver with a tenderness in the right hypochondrium, and almost no pedal edema, we can say. There was no significant pedal edema, and her chest, there were crepes in the chest. The patient was started on diuretic, oxygen, and along with the anti-thyroid medications, along with the anti-tubercular treatment and the other supportive measures. Gradually, her heart rate settled, and she was also given the beta blockers, and her symptoms also improved. So, the important thing to be noted in the among the clinical findings in this patient, as I was telling my team of residents, that when we are seeing how can we see a patient who is having 3 diseases all together in a single patient. Often nature doesn't do that to a single patient, that there are multiple diseases present at a time, that the patient is also having a pulmonary hypertension, the patient is also having tuberculosis, and then the patient is also having bronchiectasis. So there has to be some connection in between the diseases, and that is what the Occam's razor is. The principle of the Occam's razor is that we should try to explain the patient's findings with the minimum number of either a single diagnosis or the minimum number of diagnoses, which can be possibly relate all the problems of the patient all together and making a pathophysiological consequences which has led to the final presentation of the diseases in a single patient. So we have studied further and found that the hyperthyroidism and pulmonary hypertension have an important association. Since the hyperthyroidism is one of the causes of pulmonary hypertension included in WHO group 5, as we have already I have mentioned, that we reached the conclusion that pulmonary hypertension in this patient is due to 2 reasons. She might be having reactivation of the old pulmonary tuberculosis, as she is a drug defaulter, with a pulmonary hypertension leading to cor pulmonale. And this, we know that if a patient is having a widely destroyed lung parenchyma, then as a result of the pulmonary tuberculosis, then cor pulmonale can occur as a result of that, and right heart failure and pulmonary hypertension may be a consequence of that. Then the second thing was that the hyperthyroidism per se is a major cause of pulmonary hypertension. This patient, as we have seen the picture also, and we know that the BMI was 11.6 kg per meter square, means that the patient was having a hypermetabolic state. So this hypermetabolic state was contributed by several things in this patient. First is a hyperthyroidism, the second is a heart failure, and third is a tuberculosis. All 3 contributing to the hypermetabolic state, and this has led to extreme cachexia in the patient. Also, tuberculosis in rare cases may involve the thyroid gland. That is another aspect which I'll be covering in the later in my presentation. So we further hypothesize that the hyperthyroid state of the patient may be due to the tuberculosis of thyroid gland. Is it possible? So further workup was needed. So what was the further course of action in this patient? We did a right heart catheterization to estimate the pulmonary arterial pressure, which is the gold standard for the diagnosis of pulmonary hypertension. The next thing that was planned was a radionuclide iodine scan and FNAC of the thyroid gland to establish the etiological diagnosis. So this was a thyroid uptake scan of the patient, where the patient's thyroid scan showed that the patient had Graves' disease. It confirmed the Graves' disease. Right heart catheterization revealed the mean pulmonary arterial pressure was 42 millimeter of mercury, which was well ahead above the limit of the pulmonary hypertension definition, which should be more than 20 millimeter mercury as by definition. So the part of the discussion, as this is a case for early career physician, and we should take some messages from this important case, because this case has involved several specialties, One is the infection, that is the pulmonary part, that is tuberculosis. The patient was a drug defaulter and had pulmonary tuberculosis. Then there was extreme cachexia, the nutrition was involved. Then the heart failure was involved, the cardiovascular system, pulmonary hypertension was involved. So let us see the current literature. What does it say? Thyrotoxicosis presenting as exertional dyspnea and pulmonary hypertension. These are some of the important papers which we have found in this field and this area, and we have seen that the authors described several cases where they have found a association of the pulmonary hypertension which was secondary to the thyrotoxicosis presented as exertional dyspnea and palpitations. And the important thing was that once the patient was treated for the hyperthyroidism, the palpitations and the shortness of breath improved, and the patient's pulmonary hypertension indices were also improved. This is another report which is in the same thing, that the Graves' disease and pulmonary hypertension association. So this important association, this knowledge exists for long that this is an important association. However, in the clinical practice, this association is not very common to be found, but it should be considered when we find a pulmonary hypertension and dyspnea in a patient of hyperthyroidism. So all patients with pulmonary hypertension should be screened for hyperthyroidism, because the treatment of hyperthyroidism can reduce pulmonary arterial pressure. So it is a reversible cause of pulmonary hypertension. Potentially avoid the side effects and cause with current therapies for pulmonary hypertension, and limits the consequences of untreated hyperthyroidism. I will take 1 or 2 minutes more over the possible mechanisms, which include the enhanced catecholamine sensitivity causing the pulmonary vasoconstriction, a reduction in the pulmonary vascular compliance, and an increase in the vascular resistance. These are the important mechanisms. Then the increased metabolism of intrinsic pulmonary vasodilating substances, prostacyclin and nitric oxide. Then impaired metabolism of vasoconstrictors. So there is something to be done to be dealt with vasoconstrictors as well as vasodilating substances. There is some imbalance due to the hormonal imbalance present in the Graves' disease and the Hashimoto's disease. This autoimmune process, including the endothelial damage, may play a key role in this. However, this mechanism is still not very well understood. So one or two slides about the tuberculosis and thyroid. What is the fact? Tuberculosis of the thyroid gland is a very, very extremely uncommon disease, and primary involvement of thyroid is even more rare. Diagnosis is often difficult. Clinical course of the disease may resemble toxic goiter. Histologically, the presence of necrotizing epithelioid cell granulomas along with the Langerhans giant cells, which are the hallmark of tuberculosis anywhere, that is the same thing in the thyroid, is there. Demonstration of acid-fast bacilli by Zn staining confirms the diagnosis. So this is a paper from where these pictures has been taken, and these are the micrographs showing caseating granulomas in the thyroid gland. So it is observed that certain tissues are relatively resistant to tuberculosis, and thyroid is among those tissues along with the heart, striated muscles and pancreas. However, we know that tuberculosis is a condition which can involve any part of the body, but thyroid is relatively resistant. So what are the reasons for the rarity of the tuberculosis of thyroid? The prosperous lymphatic and vascular supply, the well-developed capsule and high iodine content of the gland, and we know that iodine in itself is it's antiseptic. Colloid possessing bactericidal action, destruction of the tubercle bacilli due to increased physiological activity of phagocytosis in hyperthyroidism, and possible anti-tubercular role of thyroid hormones. So to conclude, hyperthyroidism is a reversible cause of pulmonary hypertension. When the underlying hormonal imbalance is corrected, the result is improved cardiovascular outcomes and symptoms. Therefore, it's important to be recognized it is a reversible cause of pulmonary hypertension. Usually, the etiology in these cases is toxic multinodular goiter, but it can also occur with other causes of hyperthyroidism. Tuberculosis of the thyroid, although a rare entity, should be kept in mind as a differential diagnosis when evaluating a thyroid nodule. The final diagnosis is made on histopathological examination. In our case, the patient refused for the histopathological examination, so we could not do a biopsy or an FNAC, but if there is such a case, we can work up further with a tissue diagnosis, which is the most important part of the diagnosis. Thank you so much for your patient hearing.
I think before we should ask any question to Dr. Jalil Fatima, would be good that if expert Dr. Jyoti Vajpayee give her comments.
Very beautifully describe this case by the ma'am. So this case has three major points like hyperthyroidism, lung diseases, and pulmonary hypertension. It is very clearly said by ma'am. So one thing I would like to highlight, first of this case is known of hyperthyroidism with pulmonary hypertension, but my concern was that is this patient is suffering from chronic hypoxia, because sometimes patient if and because lung pictures are not too good, there is a bronchiectasis, there is a restriction in the left lingula and lower lobe, there is a different shadows, various shadows, and there is a history of tuberculosis. So first to find out this is a case of post tubercular lung diseases or it is an active tuberculosis. So to differentiate these things, we have to go for CB-NAT examination for sputum, and if any possibility of bronchoscopy to do BAL to know the infective stage, because yeah, ma'am rightly said that hyperthyroidism, to know the thyroid profile of the patient, we can revert back the pulmonary hypertension. This is so any pulmonary hypertension patient, we have to go for thyroid profile. But in this case, this patient is suffering from lung disease also, and she had a history of tuberculosis in the past. So as in the class 3 group 3 pH, there is a due to the obstructive lung disease, restrictive lung disease, and due to the chronic lung diseases, they can cause also pulmonary hypertension. So this cannot be denied that this patient may also had class 3 pH in this case. So for this, first to find out by the bronchoscopy, or also one more important thing in this case, to find out the diameter of aorta and pulmonary artery on the CT mediastinum pictures, to find out the ratio of aorta and pulmonary artery, how much pulmonary hypertension can be visualized on the CT scan. So yeah, this case is hyperthyroidism with pH, but it could be the possibility of TOPD, yeah, tuberculosis, obstructive pulmonary disease, pulmonary hypertension in this case, because in Western, the pulmonary hypertension came from the Western literature since 1973, and this classified by the Dana Point classification. Different classification has been given, but in recently the 6-word symposium, the classification has been changed. The group 5 groups on the basis of 5 groups, the pulmonary hypertension has been classified. So because in the Western literature, the TB incidence is very less, so they have not very beautifully described what are the mechanism. But in Indian scenario, the post-tubercular pulmonary hypertension, yeah, TOPD patient pulmonary hypertension is very common. There are different mechanisms due to destruction of the parenchyma, destruction of the vasculature, and arteritis, vasculitis. These are the mechanism for development of pulmonary hypertension in this case. So I would like to highlight this point. Maybe this patient is having hypoxia due to the lung disease. So if we can revert back the hypoxia, it could be revert back, not to the extent, very much extent, but it could be benefited to the patient. And one more thing, in this case, by doing the right heart catheterization, the pulmonary artery pressure was, I think, 40. So it is a moderate kind of disease. So in respiratory diseases, the pH occurs in the mild to moderate disease. If any patient who is having a respiratory disease and suffering from severe pH, so it could be due to the multifactorial factors, like in this case, because this patient RVSP, right, systolic pressure was 60. It was high. So maybe this patient suffering from multifactorial mechanism like tuberculosis, post-TB incidence, bronchiectasis, lung parenchymal destruction, along with hyperthyroidism. So this case could be the possibility of group 3 and group 5 pH combination of these two diseases also. So this is my point on this case. So anything else, if you would like to comment, so please go ahead.
Very nicely moderated, Dr. Jyoti. As you are running a clinic on pulmonary hypertension, if I'm not wrong, is it right?
Yes, in the collaboration with the cardiology, we are running the pulmonary hypertension clinic on Tuesday and Friday. So any patient who is
My
suffering from...
two questions are there from you.
Yes.
And another question I would like to have a comment of Dr. Jalis also. One is that in your pulmonary hypertension clinic, how frequently you have seen this association of hyperthyroidism with pulmonary hypertension? Do you really find it very frequently?
Not really very frequently as per my point of view, because we are a pulmonologist and most of the thyroid cases went to medicine department. So not...
But once they will be having the pulmonary hypertension, they must come.
Yeah,
to your
because we
clinic.
have recently started, maybe they, but in our scenario, we have most of the lung, just like in a case presented by the ma'am, in both the things could happen, not isolated hyperthyroid case with the pulmonary hypertension. Very rare, sir.
My second question is, first I would like to have the comment of Dr. Jalis, then I would like to have it Dr. Jyoti Bajpayee also. As you very rightly said in the beginning of your presentation that association of the hyperthyroidism and pulmonary hypertension is not unrelated, but it is not so common. It is not very frequently seen.
Yes.
So, in this particular case, what could have been the trigger factor? One, the severity of the hyperthyroidism, pulmonary tuberculosis, or heart failure. Three things you have mentioned in your presentation. So, what could be the triggering factor which caused this pulmonary hypertension in this particular hyperthyroidism individual?
I think that is the all the several factors which even Dr. Jyoti has very rightly pointed out. One important thing that she has said, that chronic hypoxia may be a reason in this case, because the patient was suffering from tuberculosis in the past, as well as in this time also CT we have seen that there was some evidences of activation or reactivation of that tuberculosis. So all
Chronic hypoxia must have been the factor which was coming from
yes.
all the three things, means
Then
pulmonary
acute
tuberculosis and
But then acute hypoxia also added upon, which was reverted back once we started the patient on diuretics and oxygen therapy over the 2 or 3 days of hospital stay. She had a profound effect in her finding. That means she was off oxygen, she was able to she was up and about, and there was almost dyspnea was markedly reduced. She was able to lie down comfortably, she was able to sleep. So, and also the hyperthyroidism treatment was also started, and she was put on for the tachycardia also. So all these facts, the hyperthyroidism has made it worse. The problem that she was having, the tuberculosis which has destroyed the lung, and the patient, the destroyed lung, we all know that the secondary to the pulmonary changes, the pulmonary hypertension which comes under the class WHO class 3, that is an important and recognized cause of very common cause of pulmonary hypertension. But then this hyperthyroidism which was associated, that has made the things worse, that has worsened the scenario. So it added upon the whole clinical picture with which the patient has presented. And another thing which you have asked with Dr. Bajpayee, that maybe she is a pulmonologist, so she may be coming across many cases like that. But even in my own clinical practice, I have not seen many such cases with such association. So it was something which has just made a curiosity in my mind. That is why
I think she's also saying the same thing. She's
I
also
have
saying she has
commented.
not seen.
Yes.
Yeah.
Yes, sir. So I just gave the residents this message that if you find several different things in a patient, try to correlate those things in a same, because the nature doesn't do that thing that causes several diseases at one time in a single patient. So try to explain that with a minimum number of diagnoses which you can. That was the thing.
Dr. Jyoti would like to have any comment?
Yes, so one more thing. There are literature on hyperthyroidism and pulmonary hypertension, not there is no RCT and no other type of problem. There are some case series about the 45, 60 patient, 23 patient. So they have shown the relationship between the pulmonary hypertension and hyperthyroidism. That they showed that about 20%, some studies show that 20% cases of hyperthyroidism having the pulmonary hypertension, and some said the 60%. So this variation have been seen in Western literature, where about 20% cases of hyperthyroidism are associated with pulmonary. So this is a good thing. Any patient who is coming with the exertional dyspnea, or we suspect this is a case of pulmonary hypertension, we have to go for thyroid profile check for those patients. This is the one message. But in India, if there is a lung diseases and destruction of so much of lungs, so class 3 pH is more common, and these factors are more prevalent to predispose or to over the pulmonary hypertension, I think so.
Yeah, this is a very good learning that if you are finding pulmonary hypertension, then hyperthyroid function test should also be done. Dr. Prabhu, you are also there, and you are also a very eminent clinician. Would you like to comment on this case? Could you see any such association in KMC at your institute?
I have seen one case, sir, but it was not active tuberculosis. Other thing, what I wanted is that this case, I think that AFB was not positive, but she had a extensive destroyed lung. Probably she had definitely hypoxemia-induced pulmonary hypertension. In addition, thyrotoxicosis, graves or whatever, it would have been precipitated crisis, which she came with immediately, like carpulmonary like feature. Probably, I have seen one case with the thyrotoxicosis with pulmonary hypertension, but I have not seen so many cases of this association. But that patient didn't have active tuberculosis or anything. Patient was a case of respiratory disease, developed thyrotoxicosis, came with atrial fibrillation and severe pulmonary hypertension. And this any case of pulmonary hypertension, any cardiac disease, thyroid function test is mandatory, because hyperthyroidism or hypothyroidism both will contribute to in the pulmonary hypertension and also in diastolic hypertension. So we do routinely thyroid function test as all the patient. In the ICU setting, role of thyroid function test is little controversial, but when you pick up that patient has got gross hyperthyroidism or hypothyroidism, that will make the treatment much more easier, and probably the treatment itself relieves the many of the components, which as already both madams have told. We screen for the thyroid function test is very important for all the acute cases and all these cases. Thank you, sir.
Thank you. I think it has been a very interesting discussion today. One of the best case presentation in the ACP case file, we can rate it, and wonderful moderation by Dr. Jyoti Vajpayee, and nice comments came from Dr. Prabhu. Amit would like to go for the next part of the program. Amit,
Yes,
I think Dr. Bashir Thakur is already joined, so we can move on to the next part.
Thank you, sir.
I think, sir, it was really a very, very excellent case discussion, and it was a great learning for all of us. And I think it will be of great interest for people who will
We should
watch
be
it later
grateful
or
of Dr.
will be
Jalil
there on the
Fatima.
ACP India Chapter
Despite
website.
being not well,
Yes.
she could manage
Yes,
to
yes.
come
Ma'am,
and
very
share.
wonderful case presentation, and very well moderated by Dr. Jyoti. Thank you very much. So now we have with us Dr. Bansi Sabu, sir. Dr. Bansi, sir, please switch on your camera.
With the permission of the governor, I would like to thank Dr. Jyoti Bajpayee for the moderation. Very nice. Thank you.
I think when I am thanking everyone, so aap sabke taraf se I am doing that. But you can do individually too.
So I will request Anuj sir to introduce Dr. Bansi sir and to proceed with the session
Hello.
today. It's very interesting. We are going to talk on the mentorship. And I think we really have two stalwarts who have a lot of in India. One is Dr. Anuj Maheshwari, our own governor.
इसकी आवाज दिया है मेंटरिंग पर 15 मिनट बात कर लेते हैं.
Right.
Dr. Bansi Sabu does not need any introduction, at least in India. Outside India, also he may not be needing any introduction certain extent, but in India, in the group of the physicians and group of the diabetologists, group of the endocrinologists, nobody would be there who is not knowing him. But just for a customary and just for a trend, I need to give some
I
introduction.
don't think, I mean, you need to introduce me. Only tell that, you know, he's close friend of mine.
Yes,
Because Anuj
obviously.
is known everywhere. People across the country know him. Now, you know, US people also know him. And Japan, he is very closely linked somehow. So the American College of Physicians, Japan chapter keeps on inviting Anuj. So if he tells that he is my close friend, people will know me.
Yes, definitely. No doubt about that. That Dr. Bansi is the close friend of each and every physician in the country, and I am little more privileged than others that he always gives a kind words and have his kind opinion about me. So, Amit, should we start the discussion?
Yes, sir, we can start the discussion.
Because without wasting much time, today's program we have focused on this part or for early career physician on mentorship. Mentorship, what I understand, has been the same extension of the same tradition of great Indian tradition, what we call that the Guru Shishya Parampara, if I am not wrong. I don't know, Dr. Bansi, what Dr. Bansi is going to give the explanation. Maybe it's different from others, but this is my understanding. So I would really love to listen from Dr. Bansi. What is the concept of mentorship nowadays? Is it changed from those ancient Indian concepts? Who should be the mentor? Who should qualify to become mentor? Over to Dr. Bansi.
So first and foremost thing, Anuj, once again, I am thanking you, Amit, and the ACP organizing team, India chapter, who had invited me. I'm really very much grateful to all of you. As you had said that Bansi is known to and friend of many physicians, that we will definitely see once the election will be over. Now, regarding this topic which you had asked me to talk on a mentorship. So first, I don't agree that only young mentee should be there. You may be a senior guy and still you may require the mentor. That is number one thing. The second is, it does not mean there is any age for someone to become mentor. Someone like very young person like Anuj can become the mentor of hundreds of physicians who are looking for that what Anuj is doing. Now, it's a relationship. Someone may call someone who is very senior, like we all are looking as far as research is concerned in India, in field of diabetes. Everybody thinks that like Dr. Mohan is one who is the one we all look up to him. But that does not mean that he will become mentor for every one of us. That possibility is there or they may not be possible. It depends on your relationship, on what topic, on what particular thing, aspect you are working on it. So there are multiple ways which we can define. Now, we normally call someone as a guide, sometimes we call as a teacher, or we call as a mentor. Now, to understand these three things, are they same or are they different? That's, I think, most important thing, and I think that requires discussion with all of us, because these are, he is my teacher, he is my guide, or he is my mentor. So these are the three things which we normally have. Like I was having a postgraduate, I have done with under one teacher. Then we have a guide for our my PhD where we had a guide. We call from the university also, they don't call teacher, they call it guide. And then we call someone as a mentor, who is actually mentor is like someone who is hand holding you. And that is a relationship much more closer than a teacher or maybe a guide. A guide may be a navigating, He may be telling you for one particular, like when I was doing a PhD under a teacher, he or she may not be every day teaching you, but he may be a guide for you, just to tell that these are the things are to be done in this aspect, and then you have to do on your own. It's like a coach. So a player is he has to play the game. The coach only explain him. And then guide word is more with the medicine people. We all know that we can't become the masters of the medicine. That's the reason we are called as a doctor of medicine, because our textbook name is also Principles of Medicine. It is not like that everything, whatever they are teaching, it is like in between the lines, you have to know yourself only. It is like the basic principles are taught in the medicine textbook, but you have to see the patients and you have to apply those principles in that particular patients. And that is what bedside medicine is completely different. What we read, that reading is a principles of medicine which you can read. So that is the similar way. The guide is actually guiding you, and you have to understand in between the lines also. The teacher is in a younger age, when we are student or as a medical student or even undergraduate student, teacher is also directly look you and see each and every aspect. But again, the teacher is responsible for hundreds of students or thousands of the students. So he may not handhold for each and every one. Once someone become a mentor or mentee, then you know that relationship is directly or closely linked with that mentor, and you are getting that mentorship from that particular expert. So he is teacher, he is your guide, he is your coach, and he is telling you not only about that particular aspect of medicine, but he is teaching you all the aspects of the life. It is like how to live that. You know, if somebody is practicing medicine, so or somebody is practicing diabetes, it is not only he has to or learn only the diabetes aspect of it. It is, you know, how to do the practice, how to talk, how to get, the conferences, how to go and learn the things. And suppose if he is not the expert in one particular field, still he can suggest or he can say you that on this particular field, you have to go at that particular place or to get the information from that side. So these are the differences which we can say broadly that there is a difference between a teacher and a mentor. That's one thing.
And even in the personal life, we can guide how to.
Yes, exactly. So that is what the second thing is. Other than that mentorship, it's your personal life growth is also been taken care by the mentor, not by the guide, or may not be by the teacher. Now, in older days, there was a Guru Shishya system. Again, in that Guru Shala or that in Guru Shishya, many of them were used to be mentored, because that time the number of students were not so high. Now in the schools, you can see thousands of children are there and few hundreds teachers are there. So it may not be possible for one-to-one that each teacher is attached with you. And that time was, in Bal Avastha, when they were having the 25 years or in those years of studying, the student used to stay in those ashram only. They were not supposed to come to home. So they will learn everything. It is, art of living you will learn from those ashram, not just few things only. It will be like for everything you will be learning.
If we talk about nowadays,
art of living. Yes, Anuj.
Dr. If we talk about nowadays, that this program is for the early career patient. Hello, can you listen me? This program. Hello.
Yes, I'm sorry.
Am I audible?
Yes, sir. You are audible.
If we talk about present days, this program is for the early career physician. So would like to have your opinion. Why do a early career physician have mentor? If he has to have a mentor, then how should he choose him? What qualities a mentor should have for an early career physician?
So again, it is like we meet hundreds of persons in our life, and you cannot become the friend for everyone. The similar way, you may see hundreds of top guys in your life, but you cannot choose them as your mentor. They may be great, but still you may not like it, or your relations may not become so great with them that you can choose them as a mentor. So this is the similarly, what I will say that it's not the quality, it's the multiple things which are responsible for someone to become a mentor of one particular person. The mentor could be your friend only. He can be your senior. He can be your teacher. He can be the local person. He can be placed at a distant place, or he can be even a person who can be even outside the country also. Only thing, how closely we are linked with him, and how closely we are associated with him, and how closely we are talking, or how closely we are meeting with him, that is also important. Many of times, the mentor and mentee relationship in such a way that even mentor is also learning many things from his mentee. A teacher is also learning many things from his students too. And it's like a medicine is such a branch where everything is getting evolved. So every time we are learning, like in this interactive forum also, we are learning from each other. We may share our knowledge, but at the same time, we are learning from each other. So I will say the mentor qualification will be, if I say someone who should have a philosophy of sharing the knowledge. And he should also have a feeling that others should grow simultaneously. There are some great persons, internationally and nationally also. They may not like others to grow in that way. But a mentor would like to see that his students or his mentee, they should grow, and they should grow more than him. That is what the first quality which I think a mentor should have. And that is the reason we always see that a mentor should be very senior. So, if he is already above the age of 60 or in his retirement, probably he could be the right mentor, because then there won't be any competition or jealousy sort of. Suppose both of them are in a similar age group, or maybe someone is only 40, 50 and someone is on 25, 30, there may be a possibility that this mentee or a new or upcoming physician in a 5 years or 10 years line, he become too big. And the person who was originally a mentor now may not be that great in that, as far as practice is concerned. So there may be a competition feeling can be there. And that's the reason we always try to find out the mentor should be like who is almost on the retirement, on the verge of retirement, and an upcoming physician would like to become mentee who is in his 20s or in 30s, in early 30s. So that sort of a relationship will grow in a much better way, because for next 10, 20 years, this guy is growing and he is supporting him by all the means. And as he does not want now him to grow further as far as his career is concerned, either as in academic or in his professional or his in organizational or his clinical, career. So there won't be any competition, and these mentor and mentee relationship may grow more in compared to those who are in a narrow age gap. So that's one difference. But sometimes two friends can be also, like I always look upon Dr. Anuj Mestri, and he is my mentor. So, in many ways, so we learn each other. So it is not necessarily the mentor has to be only one only. You may have multiple mentors, because you may learn one thing from one person, and that he may be your hand holding for that particular thing, and some other person who may be your junior or senior, but you are learning a lot of things from him, and he is also hand holding particularly for that particular field. So I may suppose for your organizational skill, you may have different mentor. For your clinical skills, you may have different. For your personal life, you have a different mentor who may be your guru, or who may be your dharam guru, or who may be anyone, So these are one may have a different mentors in the life. And that, as you are saying, and today's our meeting is primarily for young upcoming physicians of our country, to whom they should look for as a mentor. Now, first and foremost thing, we have to decide that what type of they are looking for. Is it their clinical mentorship they are looking? Are they looking for their academics? Are they looking for their organizational skill? Or they are looking for some soft skill for which they are looking for a mentor? That is very important. And now with even research also, which is very important in upcoming field for this. The next 2 minutes. 2 more to 5 minutes more. So that's a thing that they can decide that whether they want in which particular field. And then accordingly, they have to find out a right mentor also who can support them. Now, for few of the things, they can go for the locally also. And for few of the things which they can also have the mentor outside the country or outside the city or outside the state too. So it depends on what type of skill which you want to learn and what is your zeal, what you want to know. Everyone does not want to become everything. You may require some of them want to know more about the academics. Some of them want to more of a organizational skill. So like I am the one who is mainly interested for our organization to grow. Now, why organization? Because one person is not complete. One may not do everything. It is not possible that me or Anuj can do the research also, our clinic also, the academics also, teaching the students also, getting their PhD also, and doing a lot of new things for our country. That may not be possible. But if we are in organization, there is a possibility that 10, 20, 30, 40 persons who are leading the organization, they can do everything, because you will have all different type of persons and everyone have unique quality and everyone can mentor multiple persons also simultaneously. Then as an organization become like an institute, because then you can mentor also multiple people across the country, because that organization should continue to grow over a period of time. And that is what change is required. Over a period of time, you have achieved one thing, and then the second aspect of the thing will be further developed when you will get new mentee. So that is what the mentor-mentee relationship. But in India, we have at present more than 50,000 physicians. We know, if I just talk about the diabetes care, ideally we should think that in last 20 years, so many physicians have started practicing diabetes care. But if you see last 20 years data in our country, the overall improvement in diabetes care is not improved. Still, our 2/3 of diabetic patients are not controlled. They are not monitoring. Clinical inertia is still as it is. We have more than 50% of our patients who are not having more than, escalation of therapy is not done for them for the right time. Insulin is still delayed. So there is no difference is happening even after so many newer things and new medication had come, and so many doctors have come also, and they are attending the meetings and they are doing everything. So I think somewhere down the line we are lacking. Even all of them are getting MD medicine. All of them are getting and reading the same textbook which we all are reading. So that aggressiveness, that getting a right treatment, achieving a tight control, teaching the patients every aspect of a diabetes, I think that requires mentorship for the doctors.
There is an old saying, Pansi Bhai, there is an old saying that teacher and doctor should not speak pleasant or don't speak pleasant. So my question is to you, that is it necessary that mentor should be our friend?
I don't think that teacher may not speak, every time sweet, but mentor should, I think most of the time he should speak sweet only. That is my feeling. I may be wrong. I don't know. Amit, your opinion for that. He may say something else. But this is my feeling that a mentor
sometimes
should
bitterness also teaches a lot. Sometimes you are not
but
friend, but still you learn.
Teacher, because Anuj, that happens more with the teacher. If somebody is a mentor, it's a continuous relationship that should grow in between. If there is a bitterness in between comes, the mentor is telling that bitter thing just because he wants to teach or educate that particular mentee or student. But sometimes that may strain the relationship, and then this relationship may not grow as a mentor-mentee. There is a possibility like that.
Yes. Many times any generation gap or gender gap comes between mentor and mentee.
Generation gap and gender gap may not be related to when it comes to the clinical or a organizational skill or academic skill come. But when you talk of is a other personal development, the other aspects of the life, there it can have issue.
Generation gap may be there because some
yes, the generation gap will be definitely, because a 30 years old, somebody who is 70 or 75 or 80, he may think completely differently, while a 50-year-old, a 20-year-old guy. So 3 different generations will have a difference, but not for the clinical development, maybe for other aspect of the development. Definitely.
Now it is a trend that many people look for a mentor in other countries, especially the European countries, Western countries. So what is the motive behind that? Does it really solve the purpose, or it is just for the fashion?
No, it's not like for the patient. Sometimes we really get, the Western people, and they are really good and they really support you for many aspects of the life, not only for the research, but for clinical aspect or even for your relationship, which they can create for you. So it's not like that you cannot have the mentor outside the country. It is not for just for the fashion or somebody just trying to show that, I have a mentor who is from US or from UK or from Europe. But yes, it depends on, but how continuously you can keep and maintain the relationship, that is also very important. Some of them, they have done the fellowship for 2 weeks, 6 weeks, 8 weeks, and then they can create that type of rapport, and then they can maintain that rapport lifelong, and they can have mentor like him, and then he can continue to, educate you or mentorship you lifelong. So that relationship can be maintained. I don't think there's nothing wrong in to have a mentor outside the country. As I told you, mentor also not necessarily one will have only one mentor. One can have multiple mentors also, depending on the different type of clinical situation.
How frequently a person should connect his mentor?
What you are saying? I'm sorry.
How frequently a person should connect with his mentor?
I mean, it's a continuous connection. It does not mean continuous connection mean face to face or physically we are always connected. But it is like you are connected emotionally, you are connected distantly. You know what you are doing and what is your relationship. So in a different way, the connection may be there. It is not necessarily the face to face, only you have to meet every time. But yes, definitely more frequent physical meeting will definitely help you to grow better, to understand each other much better. But now distantly, like we are connected each other, we are also emotionally connected. So there are multiple ways. And now, with the email, with the WhatsApp, with multiple ways of doing the messages also, we are getting connected. So you are e-connected, you are distantly connected, you are digitally connected, physically. But I think a continuous connection is must for them.
So, thank you, Dr. Bansi. I think you are also being called constantly by someone. So we should end this program now. Amit, do you have any question? Dr. Jalees, Dr. Jyoti, if you are connected, do you have any question? Dr. Bansi Sabu, please, you can come up. And it's really has been a great pleasure today that Dr. Bansi has taken out time for ACP India chapter and given us insight about the mentorship. Mentorship is a part which is requiring a lot of clarification and consistent enlightening for early career physician. A lot of confusion is there. Many early career physicians say that we don't need any mentor. Many people, those who are coming up, just completing the residency, they say that we don't require. So it is very much important to tell them and make them understand why do they need mentor. So Amit, if you are here, and Dr. Jalees, if you are here, you can comment very frequently. Otherwise, we can end this program. Yes.
Oh, thank you, sir. Just wanted to know how can one be a part of this program, because it is a very lucrative and very important thing. When many a times we feel that in clinical practice also, as even after more than 20 years of clinical practice, we need to have some opinion from others. So that is a very important, and I never hesitate in taking opinions and taking the advice of others. So how can we be a part of this mentorship program?
The first thing, if you talk about our ACP platform, one should become the member of ACP India Chapter. ACP member of the ACP India Chapter, he will automatically become member. Don't need to take any separate membership for the India Chapter. Once anybody becomes member of the American College of Physicians, he will automatically be the member of India Chapter. And once he will be or she will be the member of the India Chapter, then we all remain connected and we all remain available for him for any help, may it be mentorship, may it be any other kind of the networking, may it be for teaching, may it be for CME or even case presentation. I think no other organization in India is there in which a senior professor like Dr. Jalees Fatima is ready to present the case for the clinicians to make them understand. And I think this is our aim, and this is exactly what we wanted, that senior people should give the advantage of their experience to the early career physician. Because what we have always realized, that early career physicians are knowing much. They have got much updated, and sometimes they are more knowing than us, because they are just completed the textbook. They are just coming out and they're just passing out from the qualifying examination. So they really need our experiences and what we can share in this way, as you shared today, as Dr. Banshi Sabu shared today. So in this way, that's why this program has been designed to help the early career physician. That was our motto, and it seems that our motto is becoming successful. So
Thank you, sir.
Yes.
I think it was really a wonderful discussion. But if Bansi sir is still there, sir, I would like to ask one question. This is slightly on the lighter side. How many mentors one should have? Because sometimes it
I
can.
think
monitoring
Dr.
by glucose meter.
Sir has
Out
joined
of
other meeting. So
Right.
Yeah.
Okay. Maybe Anup sir can answer that.
Yeah. What is your question, please?
Sir, my question is that many times there is a dilemma that how many mentors one should have. Because and second thing is that sometimes the mentor-mentee relationship doesn't work out. Because so how one can end that what is the usually how one should take this relationship forward after that?
Yeah, in fact, Amit, it's not always necessary that mentor-mentee relations will be working out like a friend. Many a times we can be having a mentor which may not be very much friendly to us, because sometimes we imbibe the qualities of the other. For example, in our times, our teachers were not having any friendly relationship with us, but still few of them becomes our mentor. We just watching them, and we start thinking them, we have to become like this. We have to be in our future life like this gentleman, like this. So this kind of the mentorship that many a time does not come when a person is having liberty to talk his mentor or talk his teacher. Once he is already back, so I think he can answer better.
So Amit was asking that how many mentor one can have. So Amit, you are already having multiple mentors, and you are also mentor of many, I'm sure. So you have mentor like Anuj Meshri, you have mentor across the world also, and you also mentoring many people also across the country. I'm sure, and many are looking for that. Everyone wants to be like Amit.
Amit Gupta is a great source of inspiration for many.
Exactly. How actively he is working in a different organization. That itself is like, Shashank even started talking for Amit, like, so you have become mentor for even Shashank also. So it's like that. So I can say that one of the, yes, madam.
I have saved Dr. Amit's name as Dr. Amit Young Researcher.
Very good. So this is what
I am really
great
blessed. The kind
You
of
can change young mentor.
yeah.
And Dr. Anuj Maheshwari's statement just reminded me of that classic thing which Eklavya used to do, that he just used to observe. He just made an image that this is my teacher and I have to become like him. And he just practiced and became like him. Much better. So
That was also a kind of the mentorship.
Yes.
In old days.
That was the time when distantly people used to, imagine for his teacher, and then, they may not get anything from him, but, like a Dronacharya was having for the Khan, it's like that.
Eklavya.
So, Eklavya, not sorry, Khan, for Eklavya. So, like, Eklavya was never the student of him. So, similarly, that sort of a mentorship is also there, and I'm sure many of students, they might be seeing Dr. Anuj Meshri as a mentor. Even Manoj may not remember them, he may not be meeting them also, but still he's mentor for many of us.
Thank you, sir. And with that, I will remind you that other meeting is waiting for both of you to join RSSDI. So for the Save the Feet campaign, so please join that meeting. And on that note, I would like to thank again Dr. Bansi Sabu, Dr. Jyoti Bajpayee, Dr. Jalis Fatima, and our dynamic governor, Dr. Anuj Maheshwari, for this wonderful session. I think we will share the recording of this session with a lot of people, because the case as well as the mentorship discussion was really wonderful. Thank you very much, sir.
Where the link is for Save the Tweet in RSD
So
EC group?
I will just share again with you, sir. Right, sir.
You can put it in EC group.
I will put it there, sir. Right, sir.
Sir, I would like to ask one thing, Dr.
Yes,
Anuj,
yes,
sir.
yes,
Sir,
yes.
I want to become a part of ACP, because first time
I
I
will
am
tell you on
collaborating.
phone. I will send you a message on the
Okay.
WhatsApp. How can you become the member of the ACP? And not only you, you also motivate your residents as well as your other
Sure,
colleagues
sir.
to become the member of the
Sure.
ACP. And definitely it would be our pleasure to have you on board.
And one more
Thank
thing, mentorship program was eye-opener for me also. So it was good, sir.
And
So this is
your mentor has referred your name to me. You must be knowing.
now I have got 2 mentors also in today's meeting, sir. 2 or 3 mentors. I hope so in
Thank you.
future being, sir.
Thank you.
So,
Thank you for this honor.
I started this mentorship program from today. So I have got 3 mentors, I think, for a further discussion for future communication.
Thank you.
Thank you so much, sir.
Thank you,
so
sir.
much.
Thank you.
Bye bye.
So
Bye,
we'll
Anuj.
next week again for the another episode of ACP India Case File. Thank you. Thank you everyone for